Hello, everyone. I'm Dr. Chahoud. I'm one of the GU medical oncologists in Moffitt that focuses on kidney cancer. I would like to thank the organizing committee for inviting me to have the chance to virtually talk to you. We'll be first talking about clinical trials 101 and RCC. So what are clinical trials and why are they done? So basically, the definition of a clinical trial is a research study that is testing the safety and/or the benefit of a new treatment approach in comparison to the existing standard of care. Why are they done? They are done to improve either early detection of cancers, improve the prevention of cancers, reduce the risk of recurrence, or improve the survival and quality of life of patients with either early stage or advanced cancers, or even refractory and difficult to treat cancers. So clinical trials, why are they important for patients with metastatic renal cell carcinoma specifically? I will walk through these four questions, and by answering them, we will hopefully answer the question of why are they important, why do we still need to do clinical trials, and why do we need to improve on our clinical trial enrollment. So did we improve the survival of patients with advanced RCC by enrolling patients on clinical trials? Yes. Did we improve the quality of life of patients with advanced RCC in 2021? The answer is yes. Can we treat advanced RCC that are refractory to therapy? Yes, and it's a continuous goal of clinical trials in RCC, and that's the essence of why we do clinical trials. We want to increase the bar of the patients that are cured from this cancer even higher every day. Can we offer clinical trials to most patients with RCC in the US? The answer, unfortunately, is not yet. Only a small proportion of patients enroll in clinical trials, around 5 to 10% in the US only. But that should be our focus and our goal to improve awareness and accessibility of clinical trials to all of our patients in the US and worldwide. We're going to go now in details to answer those four questions. So did we improve the survival? This graph highlights the multiple FDA-approved therapies that have improved the survival of patients with RCC, starting in 1992 with high-dose IL-2, which is a toxic therapy that is very, very rarely used these days. And then in 2005, all the way till 2016, you can see a multitude of VEGF TKIs that were approved. And then in 2018, with the frontline approval of the first immune therapy combination with nivolumab and ipilimumab, that was later followed over the next 3 years with 4 other immune therapy plus VEGF TKI combination that all have improved the survival of patients. So yes, these clinical trials have improved survival of patients with advanced RCC. Did we improve the quality of life of our patients? So this question is still not fully answered with these new 4 approved combination in the frontline setting. We have a clear answer for one of them that has been published, which is the nivolumab and ipilimumab combination, which is even thought to be one of the most toxic ones. But you can clearly see in this graph that highlight the scores of multiple patient-reported surveys on their quality of life. In red are the scores of patients that were on nivolumab and ipilimumab combination in comparison to the blue for the patient that were on Sutent. And you can clearly see that there was a significant improvement in the quality of life on that, the newly approved immune therapy combination. The other combination with immune therapy plus TKIs have not reported yet, but we hope and expect that at least they're going to be similar, if not better, when it comes to quality of life for our patients. Next question is, can we treat cancers that are refractory the therapy. And it's a continuous goal of clinical trials at Moffitt Cancer Center. And we currently wanted to highlight 3 of our trials that are novel and hopefully will improve and treat patients with refractory RCC. The first one is a frontline therapy that is a triplet using the already FDA-approved nivolumab and ipilimumab combination, and added to that a novel dendritic vaccine. This new technology will be combining a triplet to increase the bar of cure rate and decrease the chances of having refractory disease. This trial will be activated at our center in the next 2 to 3 months. The second trial is a trial in the second or third line therapy setting, where we're reassessing the re-challenge with immune therapy after disease progression on original immunotherapy with the addition of cabozantinib. This trial is open and enrolling, so if any of your patients or any of you feel that they can qualify, please have your patient referred. And the third is, I think, would be one of the most interesting trials that I would be looking at is a second line or above clinical in the clinical setting using the novel CAR T-cell therapy directed specifically for RCC. Hopefully this will help us move the needle forward with the number of patients with RCC that achieves cure. So the last question, can you offer clinical trials to most patients with RCC in the US? Clinical trial awareness is very important, and knowledge of how important clinical trials are to patients, and improving the accessibility is going to be a major challenge and major barrier to overcome that we will be hopefully working together to overcome. 85% of clinical trials fail to retain enough patients, 80% of clinical trials fail to finish on time, 50% of sites enroll only 1 patient on the clinical trial, 40% of the budget of pharmaceutical companies in clinical trials goes towards clinical trial recruitment. And unfortunately, we still enroll less than 3% of all of our cancer patients on the clinical trial. And that number is even less with African American patients, where the number is approximately around 1.3%. So my important message today is ask your doctors about trial options at every decision point moving forward. So to answer why are we doing that, I wanted to see from the patient perspective and some of the barrier that probably we can easily overcome: awareness. So that's the goal of this 10-minute talk, is to make patients aware that trials is an option. And it's an important question that you should ask your provider at every decision time point. Am I aware? Am I eligible for clinical trials? The concerns for side effects are legitimate, but you should have a strong communication channel with your providers and spend time to demystify some of these guinea pig myths and understand the recommendation of your provider. They can work with you also to decrease the inconvenience of the trial logistics and explain them to you ahead of time, and maybe trying to elevate some of those barriers when it comes to logistic and financial burden. Thank you.